Sebab apa? Sagi kita ada hak lain-lain buat lagi kan. Lambat tu start, lambat habis kan. So
Betul.
kita start lah.
Okay. Assalamualaikum and good evening, Dr. Fairuz, Dr. Rohayu and my fellow friends. So I'm Fareehah. Today I will present about sepsis and septicemic shock. As introduction, infection is invasion and multiplication of microorganisms such as bacteria, viruses and parasites. So it causes reaction by host tissue to the infectious agents and the toxin they produce. It may cause no symptoms and be subclinical, or it may cause symptoms and be clinically apparent. So by definition, bacteremia is the presence of bacteria in the blood. Community-acquired infection is an infection that are contracted outside of hospital or diagnosed within 48 hours of admission without any previous healthcare problem lah. Meanwhile, the hospital-acquired infection or nosocomial infection is infection that is acquired in hospital or other healthcare facility. So this is the host response of pathophysiology. So when there's bacteria and other pathogen entering the wound, the platelet from the blood will release the blood clotting protein at the wound site. So the mast cell will secrete the factors that mediate the vasodilation and also vascular constriction. Then we increase the delivery of blood, plasma and cell to the injured wound. Then neutrophils will secrete factors that will kill and degrade the pathogen, and they will remove the pathogen by phagocytosis. So the macrophages will secrete hormones called cytokine that will attract the immune system cell to the site and activate the cells involved in the tissue repair. So inflammatory response will continue until the foreign material is eliminated and the wound is repaired. So there are signs and symptoms of infection, but the symptoms depending site of infection. For example, fever, cough, headache, abdominal pain, vomiting, dysuria, vaginal discharge, rashes. Signs: patient might have tachycardic, tachypneic, diaphoresis, hypotension, acute abdomen, confusion, agitation, lethargy, poor tolerance to enteral feeding or oliguria. Then systemic inflammatory response syndrome, or known as SIRS, a clinical diagnosis associated with infection. So the criteria consists of tachycardic, which is the heart rate more than 90 beats per minute, tachypneic, respiratory rate more than 20 breaths per minute, fever or hypothermia when the temperature less than 36 degrees Celsius or more than 38 degrees Celsius, and also the total white blood cell less than 4,000 or more than 12,000 lah. So this is definition for sepsis. Initially, sepsis was defined as infection or suspected infection leading to onset of SIRS. But in 2001, it was redefined to the presence of at least 2 SIRS criteria and a confirmed or suspected infection. And severe sepsis was defined as sepsis with organ dysfunction, and septic shock was defined as sepsis included hypotension persisting despite fluid resuscitation. So, however, in 2019, the Third International Sepsis Consensus Definition Task Force has defined the sepsis as life-threatening organ dysfunction due to a dysregulated host response to infection. But for clinical operationalization, organ dysfunction can be represented by increase in the sequential organ failure assessment, or known as SOFA. SOFA score of 2 points or more. It is associated with in-hospital mortality greater than 10%. So this is the Third International Sepsis Consensus Definition Task Force. They recommend for Q-SOFA, which is Q stand for quick, S sepsis related, O organ F failure A assessment. Quick sepsis related organ failure assessment. This is a single prompt to identify infected patient who are likely to be septic outside of ICU. So this the criteria: the respiratory rate more than 22 breaths per minute, systolic blood pressure less than 100 mm per mercury, and also altered GCS. So suspicion of sepsis and organ dysfunction should be addressed when there's increase of 2 or more in Q-SOFA. This is the SOFA scoring system. Actually, this scoring system to predict for mortality. So it is based on the system such as respiration, coagulation, liver, cardiovascular, central nervous system, also renal, and also urine output.
Jap.
For this,
Siapa yang kira sofa score ni? Siapa kira sofa score regularly? Korang kira tak masa club vision? Hafal tak?
tak hafal.
GCS pun gagap lagi kan? Apatah lagi sofa score. So siapa yang kira sofa score ni? Di mana sofa score ni digunakan?
Bagi saya dekat ED. Dekat ED
Yeah.
ICU.
Okay. So sofa score ni, okay, sebelum menjadi salah faham kan. Sofa score ni is a score dekat, biasanya dia kira dekat ICU. And of course, saya rasa nak suruh semua orang ingat macam a bit impossible lah, sebab dah lah ada macam 1, 2, 3, 4, 5, 6 sistem kan. Dan each system pun ada score. The reason diorang buat sofa score ni is a score to measure organ failure. Sebab kebanyakan skor yang biasa, dia assume patient ni start normal. Tapi we've got patient yang ada chronic illness kan. Bagi contoh patient end stage renal failure. Start dah ada end stage renal failure. So skor dia, sofa skor dia tak akan sama macam orang normal. Sebab dia dah start ada organ failure. So sofa skor ni, sofa skor ni tak boleh kira sekali. Dia sofa skor ni awak kena kira masa patient masuk sebagai dia punya baseline. Then subsequently every day awak kena kira so that awak boleh monitor adakah organ failure dia makin rosak, worsen or static sahaja. Sebab tu masa mula-mula kena ada baseline. Patient punya sofa score tu baseline, mungkin score baseline dia say 4. So if sepanjang stay dalam ICU, sepanjang admission score dia remains 4, then okay lah. Tapi kalau sepanjang stay tu skor dia naik jadi 8 ke 12 ke, maksudnya it gives you an objective measure. Patient ni ada organ failure. Okay. So itu fungsi sofa score yang sebenar. Yang kedua, tak boleh buat kat ED ni. Sebab satu memang semua orang tak ingat lah. Dan yang kedua, it is a bit too complicated kalau awak nak start kira benda ni dekat ED level. That's why ada quick sofa tu. Quick sofa tu pula, patient mana yang kita kira quick sofa? Semua patient ke?
Kita suspect dia macam sepsis lah.
Okay, so apa yang kena faham, quick sofa ni kena kira inpatient yang ada infection, ada evidence of infection. Not all patient kira quick sofa. So bukan patient trauma kira quick sofa. So inpatient yang ada evidence of infection. So sebab tu kalau the latest yang surviving sepsis punya guideline,
Betul.
Sorry, banyak gangguan di belakang ni. Biasalah work from home kan. So sofa score ni dia kena kira, dia hanya dikira untuk patient yang sepsis. Sebab dalam surviving sepsis guideline, kalau tengok the progression of sepsis punya guideline ni, first, second sepsis guideline ni, dia orang try to define infection tu apa. That's why they come up with SIRS and everything. Tapi what they realise, SIRS ni, so awak tak define sepsis tadi. Kalau ikut the latest sepsis punya guideline, sepsis is a dysregulated host response to infection. And SIRS ni, ni ada awak mention kan, life-threatening organ dysfunction due to a dysregulated host response to infection. The keyword is dysregulated host response. So SIRS yang diorang duk define sebelum ni is an appropriate response to infection. So SIRS ni macam kan dia ada low BP, ada high total white cell, increase heart rate, increase total white kan. That's an appropriate response to infection. Anyone with tonsillitis pun datang kat green zone, kalau kira SIRS, dia akan cukup lah kriteria SIRS dia. So tapi that doesn't mean that the patient is in sepsis. It's just an appropriate response to infection. So that's why the third sepsis punya guideline ni, dia orang define balik sepsis tu. they're not trying to define infection. Infection is ada foreign organism datang kacau you punya body kan. Tapi SIRS bila ada dysregulated host response to infection. So SIRS, kalau SIRS tu is an appropriate response to infection. Tapi bila this appropriate response is become dysregulated, propagated and worsen, then baru dia jadi sepsis. So quick SOFA tu is something that you kira untuk patient yang memang dah ada established infection. Awak dah, okay, patient ni ada UTI, patient ni ada pneumonia. Then baru you kira dia punya quick SOFA score. Kenapa kita kira quick SOFA score? Sebab those with high quick SOFA score kena masuk ICU. Nanti ini kata orang putih lah, negara yang di mana banyak ICU. So patient with high SOFA score 2 or more, any patient with infection, quick SOFA dia 2 or more, kena manage dekat ICU. Kata orang putih lah. This is their guideline. Doesn't mean that we need to follow them. Tapi maksudnya awak kena faham kenapa daripada suruh kira quick SOFA ni. And this will come later lah bila kita kata criticism pasal criticism pasal apa? What do you call it? Pasal sepsis punya guideline ni. Okay. Oh, sorry, saya hilang sekejap daripada skrin. Okay, carry on.
Cuma yang bagusnya yang bagusnya pasal SIRS ni adalah sometimes kalau quick SOFA tu you guna untuk bila you identify infection kan, you identify dah patient ni ada infection, lepas tu you untuk identify patient ni in sepsis ke tak kan. Tapi untuk yang SIRS ni maksudnya kadang patient tu you macam ED ni dia dapat patient, maksudnya kita tak fokus lagi, tak tahu lagi patient maybe because of apa datang atas sebab macam banyak sebab lah kan. So maksudnya bila you dapat macam abnormality macam-macam tu, you boleh macam alert kata this patient might have infection. Macam Dr. Fairuz kata lah, dia boleh banyak cause yang boleh menyebabkan SIRS tu dapat 2 or more. Okay? Tapi sometimes it boleh guide tu. Dia boleh tolong you untuk identify patient ni might have infection. Okay?
Okay.
Kalau tengok quick SOFA tu bila SPP, systolic blood pressure less than 100. Lepas tu patient dah altered mental status, macam dalam apa case yang dah sepsis kan, yang teruk dah kan, dia tak boleh nak identify the early infection. Okay?
Okay. Okay. Next, then septic shock then was defined as subset of sepsis in which particularly profound circulatory, cellular and metabolic abnormalities that associated with greater risk of mortality than with sepsis alone. So clinically, it is defined as requirement of vasopressor to maintain the MAP of more than 65 or greater and serum lactate level greater than 2 millimole per liter in the absence of hypovolemia. So the hospital mortality rate is more than 40% in septic shock lah. So the mesti requirement of vasopressor to maintain the MAP more than 65, also serum lactate more than 2. So then this is the operationalization of clinical criteria identifying patient with sepsis and septicemic shock. So when patient came with suspected infection, then we follow the Q SOFA. Then based on the score, if 2 or more, then you assess for evidence of organ dysfunction. Then we look for the SOFA variables. Then score balik, tengok if 2 or more, then patient is in sepsis. Then if requirement of the if there is still need of vasopressor to maintain the MAP and also serum lactate more than 2 despite adequate fluid resource, so patient actually in septic shock lah. So based on 2016 SSC lah, SSC ni surviving sepsis campaign, actually it was initiated in 2002. So since then dia dah ada banyak evidence based research lah, guideline based on the research. So previously there was 3-hour bundle, 6-hour bundle, then they combine into single hour 1 bundle in managing patient in sepsis. So there are 5 steps. First, measure blood lactate level. Then we need to remeasure if level more than 2 millimole per liter. And then we need to send the blood cultures and administer broad spectrum antibiotics against suspected organism, start IV fluid resuscitation, administer vasopressor to raise the blood pressure. So,
Okay. Okay. So basically, yang this 1 hour bundle 5 steps ni is basically what you need to do in ED lah. This is what you guys need to be kena buat perfectly lah. Tak perlu cerita pasal ventilator. Tapi at least at your level, or even kalau you jadi EDMO ke later, in any patient that present with sepsis, these are the things that you must do dekat ED. Okay, ni kalau you tak buat, orang boleh marah lah, kata ED tak buat kerja kan. So this is the thing that you kena buat, and it's basically benda biasa yang korang buat je. I mean, measure lactate tu tak apalah, kalau boleh lah measure, tapi blood culture, start antibiotic as early as possible, because the longer you delay the antibiotic treatment, the mortality increases. So it's something yang ni. And fluid punya resuscitation banyak tau. Kalau tengok tu 30 mils per kg, and dia tak cakap patient heart failure ke end stage renal failure ke, ada different. Dia mungkin cakap bagi over a longer period ke apa semua, tapi it's fluid appropriate fluid resuscitation tu 30 mils per kg of crystalloid for patient yang hypotensive lah. And early vasopressor. Vasopressor di sini merujuk kepada noradrenaline lah, sebab tak ada vasopressor lain lah. I mean, kita tak ada vasopressin apa semua, noradrenaline lah. So benda ni lah, kalau tak ingat apa-apa pasal septic shock management hari ni pun, slide tadi dengan slide yang ni lah yang kena one of the take away message.
Okay. So other measurement is we need to stabilize the respiration, establish the venous access through the CVL, then monitor the CVP or central venous oxygen saturation, then send blood like FVC, LFT, coag, D-dimer, then ABG, may review acidosis, hypoxemia or hypercapnia, then serum lactate. So if more than 2 millimole may indicate the severity of sepsis lah. Then send the blood culture, also send the urine analysis and microbiologic culture from suspected source lah. If patient has sputum macam cough with sputum, sense sputum, then urine, intravenous catheter, wound or surgical site, body fluid. Then imaging, kita target pada suspected site of infection, contoh chest x-ray, CT of chest ataupun abdomen lah. Otherwise, this one initial resuscitative therapy. So the cornerstone of initial resuscitation is the rapid restoration of perfusion and the early administration of antibiotic. So tissue perfusion is predominantly achieved by aggressive administration of IV fluid, usually crystalloid given at 30 ml per kg, and started by 1 hour and completed within the first 3 hours following presentation. And we administer antibiotic therapy at the suspected organism and site of infection. So preferably administer within the first hour. So our early goal directed therapy based on the central venous oxyhemoglobin saturation more than 70%, CVP maintain 8 to 12 mm per mercury, MAP more than 65, and urine output more than 0.5 mg per kg per hour.
Diana, central venous oxyhemoglobin saturation tu ambil macam mana? The central venous oxyhemoglobin saturation, SVCO2 tu.
Yang ni saya tengok dia ada macam ikut CVP, tapi dia ada macam machine yang attach pada macam fiber something, tapi saya tak pernah tengok lah kat sini.
Okay, so early goal directed therapy ni is actually a term tau. Early goal directed therapy ni precedes all the sepsis punya guideline ni. I think I think it's a recommendation masa surviving sepsis punya campaign yang pertama, masa mula-mula dia orang ada gerakan sepsis lah. And early goal directed therapy ni, kalau dalam early goal directed therapy ni, nama dia pun say itself lah, dia ada goals yang need to be achieved in many sepsis. Tapi it's not evidence based. Ni theoretical je. So kalau awak follow early goal directed therapy ni, semua patient yang awak label as sepsis kena ada central line. So maksudnya kat ED lagi kena both central line. So kalau masa ni zaman saya houseman mula-mula jadi MO ni, semua patient yang label sepsis both central line. Because then you akan ambil blood daripada situ, both dalam mesin AVG untuk measure SVCO2. SVCO2 ni just venous blood gas je. Tapi kena ambil daripada central line. Lepas tu that's why dia ada target CVP apa semua. And dia ada target-target lain. Contohnya macam kalau HB less than 10 ke apa, kena transfuse apa semua. Tapi the thing that you need to remember, bukan remember lah sebab tak tahu macam nak remember. The thing that you need to know about early goal directed therapy ni, after research and people buat study pasal early goal directed, sebab ingat benda ni dia bukan evidence based, dia macam proposal lah, macam best practice. So after orang start mengamalkan early goal directed therapy ni, what they found dalam study, the evidence is kalau awak manage patient pakai early goal directed therapy or conventional method, sama saja. Tak ada improve in mortality, macam tak ada benefit lah. Cuma tambah harm to the patient sebab semua patient awak both CVP, both central line, more patient end up with pneumothorax, more patient end up with arterial puncture apa semua. So zaman sekarang ni early goal directed therapy ni is something that people talk about, tapi people dah tak mengamalkan dah lah. Tak ada dah lah sekarang awak tengok, semua patient sepsis both central line. Tak ada. And tak ada dah orang measure CVP secara rutin lah. Maksudnya measure CVP, measure SVCO2 as a marker of patient improvement ke or response to treatment. And CVP pun orang tak measure routinely because early goal therapy dia bagus, dia give a structure to management of sepsis, tapi the evidence for it tak ada, and in the end it causes more harm to patient sebab unnecessarily lah, sebab semua nak both central line apa semua, and you get more complication from all this invasive procedure. So early goal directed therapy ni is something to kalau tahu bagus lah, tapi bukanlah kata kena follow to the letter. It's something actually dah lama, tapi some of other specialty ni baru nak, masa kita duk sibuk-sibuk pasal EGDT ni, early goal directed therapy ni, semua orang macam tak pernah dengar pun. Tapi now bila EGDT ni dah go out of fashion, everybody sibuk pula pasal EGDT ni. Because kalau awak dengar EGDT ni, it sounds so good, macam structured, buat macam ni, tapi sebenarnya the evidence for it is quite weak lah. Okay, so tapi kalau sekarang in terms of management sepsis, you go for more non-invasive punya monitoring method, macam measure IVC, tengok patient punya clinical response, urine output. Urine output ni is something yang fairly non-invasive and boleh measure, tapi semua orang pun tak check kan berapa banyak urine output keluar. Patient DKA pun boleh tanya every time round, bila tanya urine output berapa, dah bagi fluid banyak, tapi you don't realise you bagi fluid banyak, keluar banyak, dan in essence balance dia sama saja. Okay, carry on.
So ni kita assess respon lah. By clinically kita boleh assess the skin colour, heart rate, respiratory rate, oxygen, MAP, urine output and mental status. But hemodynamic fluid responsiveness ada divided into static and dynamic evaluation lah. Macam traditionally kita guna CVP, SCPO2 lah, tapi dia tak influence mortality. But according to dynamic evaluation, the more reliable lah. Kita assess respiratory changes in vena cava diameter, radial artery pulse pressure, arterial blood flow peak velocity, left ventricular outflow tract velocity, time integral and brachial artery blood flow velocity. Tapi saya tak sure, saya macam untuk respiratory changes in vena cava diameter.
Okay, yang ni semua macam more pakai, kalau awak terror guna ultrasound apa semua boleh lah. Dr. Ati mungkin boleh ajar lah kot. Saya pun boleh sebut je lah, saya nak measure pun saya tak kerti. Tapi that's what I'm trying to say. Now the latest of the recommendation is to use more macam non-invasive punya monitoring, because now zaman saya houseman dulu mungkinlah satu department tu ada satu ultrasound yang specialist dia boleh pegang. Tapi sekarang zaman-zaman awak ni satu even ED yang relatively kecil macam kita pun ada 2-3 mesin ultrasound. And houseman pun boleh pegang. Cuma houseman je tak nak pegang kan. So take a chance. I mean, belajarlah guna ultrasound because you may not have the access to ultrasound as readily as macam dekat ED kan. So belajarlah dengan MO, dengan specialist, nampak mereka duk main phone tu, ajarlah saya cara menggunakan ultrasound. Macam tu lah. Okay, cuma satu lagi yang saya nak highlight, management of sepsis tu, yang macam saya cakap tadi, yang 5 steps tu kan, yang kita buat tu, benda tu memang kita buat in the beginning. Memang cepat je kita buat. Tapi another part of sepsis punya management is monitoring. This is something yang biasa kita sangat lemah lah. Bukan level houseman je, level MO apa semua. Lemah bukan kata kita tak buat. Kita buat, tapi kita tak dokumen. Perasan tak? Kalau korang punya clerking, untuk patient ED ni, dia ada ED clerking. Lepas tu mungkinlah ada satu progress note bila patient dah dapat x-ray apa semua. Lepas tu kalau patient lodger 24 jam pun, next review mungkin sebelum patient masuk ward ke apa ke, yang kita duk pergi jenguk patient, tengok SpO2 okey, pulse volume okey, kita tak dokumen pun. Jadi nampak macam kita ni tak buat kerja. So get into a habit. Lepas awak buat, this is for everyone lah. So dan habit ni bawa lah sampai bila dah besar nanti kan. Get into a habit. Bila awak review patient awak after awak institute treatment or management, just simple 2-3 line punya documentation lah. Assess patient after 2 pints of fluid, pulse volume macam mana, general condition improve ke apa, right? Cukup lah. That at least shows that you are actually doing work. So because the problem with us ni, bila tak dokumen ni, sebab semua orang akan review retrospectively kan, bila jadi isu apa-apa kan, so orang akan balik notes and nampak masa clerk je, lepas tu patient duduk kat ED 24-48 jam, tak ada orang review pun. Because nobody document. Padahal korang duk jenguk patient kan, duk sebelah patient, pegang tangan patient dan sebagainya kan. So make it into a habit to document whatever you do. Okay, carry on.
So this table for resuscitation lah. This one macam summarize je lah tadi. Resuscitation with IV crystalloid fluid 30 ml per kg should be begin within the first 3 hours. Then kita guna saline or balanced crystalloid for resuscitation. Then kalau in patient with elevated serum lactate level, resuscitation should be guided towards the normalizing the level lah when possible. So when the patient in septic shock requiring vasopressor, the recommended target MAP is 65 mm per mercury. Norepinephrine is recommended as the first choice vasopressor. Then the butamin use is suggested when patient show persistent evidence of hypoperfusion despite adequate fluid loading and use of vasopressor. Yang ni yang dulu lah, HB kita kena consultation red blood cell transfusion recommended bila HB dia less than 7 lah and absence of acute MI, severe hypoxemia or acute hemorrhage. Ni luas ni as in summarize untuk sepsis yang latest guideline tu lah. Local infection is when there's acute inflammation and pathogen clearance and resolution of inflammation. Then sepsis when there's dysregulated macam organ failure due to dysregulated host response to infection. And shock when the requirement of vasopressor lah to maintain MAP, also when the serum lactate more than 2 mmol per liter lah. I think that's all. Tu je. Doktor nak tambah apa-apa?
Saya dah tambah banyak dah tadi saya rasa. So ada soalan apa-apa? Ada soalan apa-apa? Boleh buka mikrofon. Nak tanya soalan, bukalah kamera. Saya tak confident bila nampak gambar-gambar ni je semua. Ada orang ke tak ada orang sebenarnya. So ada soalan apa-apa boleh tanya Diana? Boleh tujukan soalan anda kepada Diana?
Ada Fareehah.
Fareehah, sorry. Sebab pakai akaun Diana kan. Itulah saya kata macam Diana muka lain. Tapi sebab nama tertera ni Durul Diana.
Share.
Ada soalan apa-apa kepada Fareehah?
Ada apa-apa?
Fareehah tengah sedia nak menjawab soalan anda ni. Penuh bersemangat ni. Dia dah explain apa semua. Okay, so sepsis is something that you guys need to be familiar with lah, because it's something yang boleh kata bread and butter lah. Pretty much 80% of patient yang datang kat kita pun is in some sort of sepsis. Kalau yang tak ada sepsis pun, somebody will say to rule out occult sepsis. So it's pretty common. You see every day and it's
Allah tak dengar.
dengar. Saya dengar Kak Ayu.
Ni Kak Ayu settle pengaruh Sat lah.
Beres. Tak apa. Saya supervise. Tak apa. Okay.
Saya naik jual.
Tak ada soalan Ustaz, kita proceed next slide. Next presentation.
Okay, no problem. Carry on.
Okay, thank you Dr. Fairuz.